Good afternoon. My name is Edward Morrison. I'm a vascular surgeon at Coastal Vascular and Vein Center. An angiogram is a procedure we do frequently to assess blood vessels by injecting contrast material into the blood vessel and seeking out where blood vessel blockages occur or any other vascular pathology may be. Who needs angiograms? Remember this. We take care of blood vessels. They go everywhere in the body except for deep in the brain and the one in the heart, which the cardiologists do. So therefore, blood vessel problems to any organ in the body or any extremity of the body can come under our purview, and we can assess and do have to assess blood vessels to all parts of the body for the actual arterial blood supply and blood flow. The angiography in the whole world of what's called endovascular management of blood vessel disease is obviously in a growth phase and almost a revolution from the last 10 to 15 years, where more and more is done by what we call percutaneous or endovascular means. That is, a small stick into an artery and access is controlled, and through that you work to repair or to ameliorate your problem. Those things we do include simple angioplasty, stent placement, thrombolysis, or utilizing medicines to break up clot, atherectomy, which is cleaving out atherosclerotic plaque inside of arteries. So there are all sorts of options. Risks of having an angiogram are really patient-driven and something we discuss a lot before we make a decision. There's an idiosyncratic reaction to contrast which occurs anywhere from 1 to 10 to 1 in 20,000 people. It's unpredictable. There are people who we know are at higher risk of contrast reactions than others based on the history, and we're going to premedicate them accordingly. That is probably the singular biggest risk. The other risk is that associated with contrast. So when we do angiography, we are judicious about contrast. It's basically the load, the volume of contrast given that can have effects, especially in the kidneys. And the other risk is that of issues dealing with how you get inside a blood vessel and how you get out without injury. And that includes where we go in the femoral artery, and devices we use to close the artery and or bleeding from the groin. Good question. We have traditionally been hospital-based, and the pressures in the industry across the country is such that at Coastal Vascular and Vein, we invented no wheel. We're following lead examples set by mature vascular practices from all over the country. And angiography and endovascular management, it's become an outpatient procedure. And one of the reasons is the difficulty the elderly find in driving to a part of town or part of the city or part of the state they don't know where to park. They're entering this labyrinthine large system, and it's tough on them. What we offer is literally drive up, walk in, and your procedure is done. And as well, you're taken care of right here for your post-operative period. So the whole concept of outpatient angiography is here to stay. People come to us and say, I've done this 5 times, I don't want to go back to the hospital. And it really isn't a bearing on the hospital itself, it's a bearing on the procedures and what they have to go to get something done in the hospital. Most angiograms take under 30 minutes to 40 minutes. Again, to inject contrast takes just a minute. To study the pictures takes just a minute. It is imperative that whoever's performing angiography on you is judicious and understands the risk, benefits, and possible complications of any and everything they do. And that's something we will vocalize with our team, our techs. And you know, there are plenty of times, sir, you do an angiogram, you're finished in 5 minutes, and the family says, what happened? And I said, well, nothing, but I can't do anything. This patient needs an operation to fix their problem. And it is important to know the limitations of all endovascular management, because there's plenty of places and plenty of organs in our body that the blood supply needs to be fixed by direct surgical means. And that'll never go away, but the amount of open surgical procedures we do is continuing to get smaller on a yearly basis. We've got two options for anesthesia. One is pure local anesthesia, which is infiltrative in the groin, usually femoral artery and the skin around it when we're making our arterial puncture. Most cases, however, we use conscious sedation. Conscious sedation is intravenous IV form of relatively mild sedatives that are closely monitored by our RNs, who are all trained in administration of conscious sedation, and by us, the physicians. Conscious sedation obviously is a hot topic in this country. It has been, and I'll be the first to tell you, it's been overutilized by other physicians and other specialties with possibly sequelae of having to deal with airways, etc. We are extremely, as vascular surgeons, we're very judicious about its utilization because we've seen what can happen, and so we use small amounts and small aliquots. And usually you can talk a patient through a procedure with minimal discomfort. Rarely have to use any narcotics. Rarely any narcotics. Patients want to come here, be treated, get to our recovery room across the hall, lay down for a couple hours and be awake and be able to walk out. That's the goal. The goal is not general anesthesia. And that's one of the changing paradigms in this whole picture of outpatient endovascular management.